introduce Dr. Sumitra Kumar on my right side. He is a very, very important person from the CSI headquarters, who is the treasurer of the CSI headquarters. We have with us Dr. Ramesh Babu from Hyderabad, who is a very, very important faculty member of CSI. And we have with us Dr. Shiv Kumar, who is going to be the chairman of NIC for the next meeting at Hyderabad. I'd like to ask Sumitra, I think we see a lot of patients of STEMI in our practice. Once they come to you, what are the important variables you consider, right from home to the hospital time, and the hospital to the needle time, and the needle to the balloon time? What are the important variables which you consider? The reason I tell you why, there are going to be a lot of medical legal litigations. People say, my patient came here in the hospital in the emergency at 9 o'clock, and by the time we took the patient to the cath lab, it was 3 hours or 4 hours, and by the time a technician came and doctor came, it was 5 hours more. So should we label this patient as to have primary PCI or only PCI? Why should we use the word primary? Because that is a legal sword on us. I think it's a very important question I'm asking you, because there are already 2 or 3 cases lying in MCI to work on this. Is it a primary PCI or PCI?
Okay. The issue at stake is total ischemic time, that the moment patient has the chest pain to the time that he gets effective treatment, that is reperfusion, as we said, be it thrombolytic therapy or primary angioplasty, that is the total ischemic time. Now here problems are basically under twofold, that is, one, time spent out of the hospital, and the moment patient lands in the hospital, what is the time taken to deliver the appropriate treatment. Now time out of the hospital has 2 major entities. That is, first one is dependent on the patient's awareness about the whole problem, that I am having chest pain. Is it cardiac? I should not waste time beyond first 15 to 20 minutes. I should either report to the doctor I know the matter, or I should get whatever transport is available to me and reach the nearest hospital that is competent enough to deal with the problem. So that is one thing. Other is the infrastructural problem, the kind of ambulance service and other services that we can provide so that the patient reaches the hospital in quickest possible time. Now once the patient reaches the hospital, that is the medico-legal entity that you raised, that we should deliver the treatment in a time-dependent fashion. Now to take both the things into account, the out of hospital, there is a term now introduced instead of dot to needle and dot to balloon time, is the first medical contact to needle and first medical contact to dot time, so that the ambulance is also hospital's responsibility. The ambulance takes the patient to the hospital and starts effective treatment. Once patient is in the hospital, if he gets within a reasonable time frame, say the first 3 hours, if the hospital is not equipped enough to do the primary angioplasty, then probably lytic therapy still has a place. But if the patient comes much beyond that, then probably patient should be referred to the nearest PCI capable hospital. Regarding PCI, the time set after the patient reaches the hospital is 60 minutes. Okay, so we should try to deliver the effective treatment in 60 minutes, and FMC to angioplasty time is 120 minutes. So all these time frames are important, because not much time should be wasted in the emergency department. Your cath lab technician and other staff and the operator should be intimated as quickly as possible, so that the process can be initiated in the quickest possible time. So things are both technical, that is once the patient in the hospital, communication, and social awareness about the whole problem. So there are so many angles to the problem.
Dr. Sumitra Kumar, I think we see a lot of patients coming to us in the clinical practice there. We find there are a lot of issues. Once we tell them they have to go for PCI, they keep on calling their GP or their physician or their family members or their financial issues. So many things are there. Are they really done in 120 minutes?
Very difficult, very difficult.
The time of the pain, that's an issue. Legally, the advocate asks us, he had his chest pain at home, he spent almost 1.5 hours coming to you, and then you spent almost 2 or 3 hours, and then you did a PCI. Is it a primary PCI? The fight is only on this word of primary. Why don't we label only as PCI and forget about it?
The thing is that because time is muscle, every minute that you waste on these trivial issues, I will call them trivial because at the end of the day, the time taken to deliver the treatment is all important. The time spent otherwise is all useless and maybe harmful as well. So here again comes issue of awareness, that patients should know that this is the treatment that I have to receive in a time dependent manner to give me the maximum benefit. And other thing is that the issue of trust. That is something the hospital or the doctor in question has to develop in the patient or imbibe in the patient. So that is the three things: the trust, the dependence, and the awareness of the problem, that you have to get this treatment in the quickest possible time. Another issue is of course monetary, that is whether the individual is giving it out of his pocket or it is insurance supported, whether the insurance company is reverting in the quickest possible manner. So these are the issues to be taken into account.
It's very important, Dr. Ramesh Babu. I think we see a lot of patients, we say rescue PCI or facilitated PCI or a primary PCI. I don't know, there's no word like secondary PCI. Our objective is a lot of confusion, and this confusion is in the dilemma of the insurance company, even in medical legal problems. There is a lot of jugglery in the words. Ultimately, what is my aim? Your aim is PCI. Why we confuse the people so much? Because then they go to the details. Is it really primary PCI? Should I reimburse the money? Should I not reimburse the money? And then the question comes from the patient's mind, and he sues the doctor that they did a primary PCI. I'm doubtful because I reached 5 hours late, so it's not primary PCI. It has already created so much of damage in me. We'd like to have your opinion. It's a controversial issue.
Sure. And I think one part is the primary PCI. The second part is the thrombolytic therapy. Probably in a country like India, probably my guess is obviously the first major delay is a patient taking the call that this is a cardiac pain and going to the hospital. Probably my guess is less than 1% of the patients with the heart attack are reaching a hospital on time. When I say on time, it's less than 3 hours. And I think probably public education is so crucial that any person having chest pain, unless proven otherwise, it could be heart attack, and I think they should be asked to report as early as possible, so that at least will not delay that. I think whatever has been said and done, unless they come on time, it doesn't have a meaning. And as you rightly said, I think the real benefit happens in the first 6 hours. That's the most crucial period, and between 6 hours and 12 hours is a little, the benefit is definitely less. As other panelists said, time is muscle and every minute is good. I think the most important thing is the spreading the awareness, like in a brain stroke, first 3 hours, in a heart stroke, first 6 hours is so crucial. And I think this terminology probably we shouldn't emphasize too much to the patients, it's primary and all that. I think you have a blocked vessel, this has to be opened.
That's it.
We have two options. One is the medical therapy, thrombolytic therapy. The second is angioplasty.
Yeah.
That may be far more simpler. When compared with maybe 6 years, maybe 5-6 years ago, a lot of words were there: primary angioplasty, facilitated angioplasty, thrombolytic therapy, come angioplasty. I think make it very simple.
I think I totally agree with Dr. Ramesh Babu that there is a lot of jugglery of words and a lot of confusion creates. We tell the patient, should I give you a clot buster or should I do a primary PCI? We don't explain what you mean by primary PCI. And then there's a question, is it a PCI or a primary PCI? You say PCI, but when you say primary PCI, there's a lot of confusion in the mind of an advocate who doesn't know ABCD of medicine and the guy who is from insurance company, because there's a lot of claim issue. Why you done primary PCI? He was not a candidate for that. Should I or should I not? I think it's a very important issue, and I think I agree with Dr. Ramesh Babu. It's a jugglery of words. We should tell our patient in a very simplified manner that you got a problem of such a duration. We have two options. One is a drug intervention, and second is a mechanical intervention by PCI. I think that's a right appropriate word. We have with us Dr. Shiv Kumar, who is an interventional cardiologist from Hyderabad Apollo Hospital. We welcome you, Shiv. I think you did a lot of work in the era of STEMI with thrombolysis, what we call as a pharmacoinvasive approach. What is the message you want to give it to the audience here? Is it appropriate in today's era of intervention that pharmacoinvasive is superior as compared to mechanical intervention?
Yeah, in today's world, it is absolutely relevant and important that although there is no doubt that the invasive strategy scores over the thrombolytic therapy theoretically, but practically, if you really consider in our country, where the distances are too many and the congestions and so many things, it is practically not possible to reach within 90 minutes by which we should do a revascularization. So I feel that in our country, probably the pharmacoinvasive strategy stands much more a better option compared to the directly going for an angioplasty. So I feel, yes, wherever possible, if the patient is landing to you, as he said rightly, that from the time of the chest pain, from the time of the index, if within 90 minutes, if the patient lands into the cath lab, and if you can open up the artery, nothing like it, but if it's failing, if we know that we are getting delayed, so I think the pharmacoinvasive strategy scores over the
I think Dr. Shivkumar has given a very kind statement. If a patient is right there in the hospital get a MI, he is the right person to get intervention. We say, oh, it's a primary PCI. He is right there in the hospital, he had an attack right there, no time is wasted. But if a patient goes from outside, there is a big question mark. Should we label the primary PCI? And he used the very right word, that pharmacoinvasive is the way. He said there is only theoretical distinction. Practically, the real application, if you see, is the pharmacoinvasive approach. If you really want to salvage the jeopardized myocardium within a period of 3 to 4 hours and to give maximum benefit of morbidity and mortality, pharmacoinvasive approach is the answer. There are some patients who comes from the periphery, who are long distance. So we have to send a message across the world and across India as to what kind of treatment. They go to a pharmacy, or they ring up a GP, or they ring up a family member. They are confused by themselves about the symptoms of heart attack, and by the time they call the ambulance, it's already 6 to 7 hours, and by the time they reach you or they come to your hospital in emergency, there is no proper protocol in the emergencies, and then there's a delay in emergency, and by the time the patient comes to you, it's almost 9 or 10 hours delay. So what's your opinion on this?
Actually, I would say that we, as a CSI, the whole CSI needs to work on this, and we have to evolve a strategy. Our mission should be that every patient who gets a heart attack should get his blocked artery to be opened up either by a medicine or mechanically within 60 and 90 minutes. That should be the mission of CSI. And what I personally feel is that there are two issues in this. One is that we need to make the people aware. I think awareness is a big problem. So first we need to make people aware. And how do we do this? So probably we can use a technology here. I think if we can evolve some applications, some apps, whereby the people can know that what are the things, and most importantly, there are many times we must have seen that there are ambulances which go in front of our hospital to some other hospital, which is probably medico-legally is not a very right thing. Ethically, it's not a correct thing. So if they have an app and they know that, okay, these are the locations nearby where we know that where the primary PCI is available. So probably we can cut short the times. And similarly, like in case if we are getting delayed, so we should make them aware, even the physician, the referral physician also, that, okay, you can give the latest the clot busters like tenecteplase, which can be given very easily outside and without much of a side effects, and then after subsequently can be shifted.
Brilliant idea. I think Dr. Shivkumar has mentioned very clearly that we have to have some app. I'm sure you are the chairman of NIC now.
Sure.
If you create an app by the name of CSI Heart Smart app or Smart Heart app on how to attack heart attack, it will create a massive awareness. The word itself is creating awareness. How to attack heart attack, and then it's smart heart. It's a smart heart, and then how to attack heart attack will be a brilliant idea, and I'm sure it will happen in your year. Since the idea conceived today, and we have the conference, I think in April, maybe 5 or 7, 8 months.
7 months.
So it will be a brilliant idea. It will create a huge global impact. I am sure you have enough time to work on this. It will create a huge impact, and that's how we can improve the window period or the golden hours to treat the STEMI in a big way to reduce the morbidity and mortality. In last, I would like to have a consensus of opinion from my learned panel here. Dr. Sumitra Kumar, what do you believe? Is it a pharmacoinvasive approach or only a invasive approach for STEMI?
No, for the vast majority, if you leave aside the metropolises, if you go to the middle-tier towns and maybe the smaller towns and the villages, it is the pharmacoinvasive therapy which holds the edge, because considering India's infrastructure and cost constraints, pharmacoinvasive therapy should be the most suitable approach for a country like India. For select population living in the metropolis in the vicinity of tertiary care hospitals, yes, primary PCI option should also prevail.
I would even go a step back. I would say pharmaco and pharmaco-invasive therapy. There will be certain patients, for whatever reasons, geographic distances or affordability, they may not be able to go to a cath lab. So I think we should not completely discount that pharmacotherapy also has a role to play in the management of heart attacks.
Brilliant idea.
I think
what you
golden
use,
hour, it is as good almost as
I think what Dr. Ramesh Babu has used, if a patient comes to you in the golden hour is only 60 minutes. If any patient comes to you in 60 minutes, maybe intervention not required. You may lyse the clot, make it patent up to the tune of 60%. The remaining can be taken care of by medication. Maybe stent is not required. So you use the word pharmaco and pharmaco-invasive approach. I think you analyze it further. It has a lot of clinical impact, I'm sure. Shiv, you will keep it in mind. Then these words should come in the new app which you are designing.
Sure.
You have some other views on this.
No, I totally agree with the whole panel that probably it should be pharmaco and pharmaco-invasive. 90% of the people probably would fit into a pharmaco-invasive, and remaining 10 also maybe in the pharmaco alone, and then probably all the rest, very few percentage can get the invasive alone.
Thank you very much, ladies and gentlemen. I think this was a brilliant exposition and a lucid presentation by all the 3 learned speakers on the management of STEMI, what we should do in the year 2016 and beyond, so that we salvage the geoparditis myocardium to a greater extent, make the people aware about the heart attack, and teach them or educate them how to attack heart attack. And despite that, if somebody gets an attack, we salvage it, and we postpone the need of further intervention, as postpone the event rate and postpone the mortality and morbidity to a greater extent. Thank you very much, Dr. Sumitra Kumar, Dr. Ramesh Babu, and Dr. Shiv Kumar.